Hi. Okay, pulmonary ventilation part two. So we just sort of laid the foundation anatomically and introduced some key terms. So we are going to keep that momentum going with our pulmonary ventilation part two. Here are some of the topics that we are going to discuss. So think about, where do particles go when they are filtered in the nose? So basically we have the cilia, which transport dust and trap all of the particles that we do not want to breathe into our body. And then the humidifying of the air, we have these nasal, what are called conchae, and they swirl the air around and allow air time to humidify and warm and clean the air before it enters the lungs. So just really cool how physiologically that works. So we have introduced this idea of the ventilation perfusion ratio, and we have said that V is air that reaches the alveoli per minute, and Q is blood that reaches the alveoli per minute. So this is our VQ ratio. So let's talk about a little bit of a review, and then we'll get into what this VQ ratio is like during exercise. So we know that at rest, our V is 4.2 liters of air. And we know that our Q at rest is 5.0 liters of blood that flows through our pulmonary capillaries. So with our 4.2 divided by 5.0, that equals 0.84 liters for our ventilation perfusion ratio at rest. So now let's talk about light exercise. So at light exercise, our VQ ratio doesn't change a whole lot from our resting state, maybe goes up just a little bit. However, with heavy exercise, we actually see a disproportionate increase in our alveolar ventilation. So this means that the VQ ratio could actually get up to 5.0. Again, we'll review some of this as we go along. So I'll take a deep breath. So we have our inhaled air. That means that our rib cage expands as the rib muscles contract. And then whenever we inhale, this diaphragm contracts and moves down. Whenever we exhale air, that means that our diaphragm relaxes and moves up. And the reason why I have included these slides is that individuals that have COPD or have had a lung transplant, I was actually an exercise physiologist in a pulmonary rehabilitation facility. And one of the exercises that we used to do with our patients truly was concentrating on breathing and concentrating on the muscles and moving. Just like we talked about that term sarcopenia, where muscles throughout your body can become atrophied and smaller, the same is also for the muscles involved in breathing. So it's important to keep those strong and healthy as well. Have you ever run a race, or you've run a race and you might not have been completely trained for it, but man, you gave it your all. And this happens to me too, where I go out a little bit too aggressively, and the next day, those intercostal muscles between your rib cages hurt because you've been breathing. I'm gonna hyperventilate and pass out. You've been breathing so quickly that you're using muscles in your diaphragm cavity that you might not have used so much before. So with these muscles involved in breathing, I really just want to set the stage that during more forceful inspirations like exercise, our intercostals help lift the rib cage. And that's what I was saying about having some of those sore intercostal muscles right here. And so what do the contractions of the muscles do? And this is really important when we talk about the pulmonary system, is it's going to bring a decrease it's going to have a greater pressure difference inside the pleural cavity. And this is what's going to help move air in and out of the lungs. So this intrapulmonary pressure causes the lungs to expand, which decreases the pressure inside the lungs to about 757 millimeters of mercury. Our normal atmospheric pressure at sea level is 760 millimeters of mercury. So this pressure difference of about 3 millimeters of mercury between the lungs and the ambient air really is what drives this movement in and out of the lungs. So whenever we exhale, we begin with the relaxation of the diaphragm and the intercostals. And again, this will also allow for a pressure decrease in thoracic volume. And this can cause the pressure in the pleural cavity to increase. So airflow in and out of the lungs is due to the differences in these pressures. Okay, so let's talk about minute ventilation, which is the volume of air you can breathe in a minute at resting. So let's define some of these terms. So tidal volume is going to be air you inhale with each breath. Oh, I cannot spell. I can't spell in general, which I'm sure you all have noticed. My brain moves faster than my pencil. Our breathing rate is going to be the number of breaths you take in 1 minute. Have you ever been at the doctor's office and they just say, act normal and breathe, and they're counting the number of breaths that you take, and I know what they're doing. And for some reason, I can't breathe normally. I'm like trying to either slow down my breaths to make it seem like, oh, you work out. You have low breathing rate. Anyway, again, I wish you all knew me in person, because tidal volume of 0.5 liters times a breathing rate of 12 breaths gives you a resting minute ventilation of about 6 liters. And I'm going to put this into a really nice table for you to understand here in a second. So the volume of air you breathe in a minute, let's talk about exercise. So what's going to happen to minute ventilation whenever you exercise? It is going to increase. Why is minute ventilation, this volume of air that you're bringing in and out of your lungs, going to increase? Well, you're going to have an increase in tidal volume, an increase in the air you inhale with each breath, and you're going to have an increase in breathing rate, which will be the number of breaths that you take in a minute. So for low intensity, your tidal volume and your breathing rate will increase proportionately. During high intensity exercise, and we now know all about intensity based on that Carbonin formula with percentages dealing with heart rate. So our high intensity, our tidal volume is going to reach a plateau, and any further increases in minute ventilation will depend solely on breathing rate. So breathing rate for healthy young adults is about 35 to 45 times a minute. Elite endurance athletes will breathe up to 60 to 70 times per minute. And so our minute ventilation for endurance athletes can get up to about 200 liters. So what we're going to do right now is actually draw this out so you have a better visual understanding of what we're talking about with this minute ventilation. So here we have our x-axis. Let's make this exercise time. Let's make this, say 5 to 30 minutes. Let's make this a warm up. Let's make this a cool down. So our x-axis is going to be exercise time, and then our y-axis is going to be pulmonary ventilation in liters per minute. So we just said that for our elite endurance athletes, we can get up to 200 liters. So we'll put 200 liters here, but I'm going to put about 140 right here. 120, not to scale, but we're going to kind of do our best. Okay, so let's go ahead and make sure that we write down that this graph that we're drawing out right now is in a normal, college-aged, young adult, healthy person, no underlying pulmonary conditions. So let's talk about light exercise. Let's draw in light exercise, where our pulmonary ventilation will start pretty low. It'll peak a little bit, but again, we're just doing light exercise. So that's where our pulmonary ventilation is for light exercise. Now let's do some more moderate intensity exercise. I bet you can see where this is going. Let's draw in our heavy exercise or our more intense exercise. And then finally, we can draw in sort of our elite Olympic population, showing that our pulmonary ventilation can get up to about 200 liters. But usually, if you or I were to go to work out, we would be somewhere between that 60 liters per minute to about 120 or so liters per minute. So let's put some numbers into a table. I think this will really help make this make sense. So typical values for pulmonary ventilation during rest and moderate to vigorous exercise. There's an equation that we have that is breathing rate times tidal volume equals pulmonary ventilation. So at rest, we typically take about 12 breaths at rest. Our tidal volume is about 0.5 liters. So 12 times 0.5 would be 6 liters per minute at rest for pulmonary ventilation. Now, during moderate exercise, I have us maybe not quite to scale, tipping up to about 60 or so, but I'm going to put 30 here for this graph. This really, or for this table, this is just to show you sort of the math. Our tidal volume of 2.5, and then that will be I was right. Oh my goodness, not breathing rate, pulmonary ventilation. Look at that, I was right, 75. Yeah. Okay, and then let's go to vigorous exercise. So if we have 50 breaths per minute and a tidal volume of 3.0, that means that we are about up to 150 for our vigorous exercise or elite. But this is a great table to come revert back to when I ask questions about this on quizzes and the exam. Make sure you understand that breathing rate times tidal volume equals pulmonary ventilation, and have an idea of what these pulmonary ventilation values are at different intensities of exercise. So we've already discussed hyperventilation in a previous unit. Remember that hyperventilation was when R, E, R was greater than 1.0. So this occurs when your tidal volume of breathing eliminates more carbon dioxide than the body can produce. And this is due to, say, a physiological stress, like the VO2 max test, or it could be due to anxiety, a traumatic brain injury, stroke, asthma, just to name a few. And this can cause lightheadedness and even unconsciousness. So let's talk about ways that we can measure lung volumes. So make sure that you watched, or definitely after this lecture, make sure you watch the YouTube video of someone being taken through static measurements of their lung volumes. It's a 3-minute video. It does a really good job at discussing just exactly this, spirometry, which measures the amount and rate of air a person breathes in order to diagnose illness or determine progress in treatment. So I'm not going to spend a whole lot of time on this because I really want you to watch that video. But I do want to make a plug and say that spirometry cannot tell if you are a young, healthy person or a very elite Olympic endurance runner. What I mean by that is spirometry is only going to be used to diagnose illness of the lungs in your respiratory system. So even though I'm a much better athlete than my 70-year-old mother, while she doesn't have any underlying respiratory issues, her spirometry measurements and my spirometry measurements will be virtually the same, even though, as we've discussed, I'm physiologically amazing. So, I kid, but please watch that video. So this is an important concept here to talk about for these static lung volumes, and you will see this as a kind of a common theme and things that we talk about throughout this class. So if you go back and re-watch that video, he talks about, well, in the video, we talk about tidal volume, which is just sort of your normal resting breathing rate. What this peak is up here is when you inhale. When you exhale all of the air out of your lungs, that is down here. The residual volume will be what is left over. We have other terms like the inspiratory capacity, vital capacity. Your total lung capacity is the total lung capacity of your lungs. Inhaling all of that air, filling your lungs with air, and exhaling and releasing all of that air. So there are some typical values that we can put to this. This is showing some average values. Again, this is in milliliters. Seriously gonna get lightheaded from all of that breathing. Men, typically, again, I sometimes don't like this generalization of men versus women, but typically men do have higher lung capacities and higher volumes just from being bigger. Now, that's not always the case, but I did want to at least give you some clinical numbers here to look at tidal volume, your IRV, your ERV, really spend some time understanding the terminology associated with lung volumes if you're not already familiar. So in talking about these dynamic lung volumes and these pulmonary function tests that we do through spirometry, we know that adequacy of pulmonary ventilation depends on how well an individual sustains high airflow levels rather than on movement in and out of a single breath. And so this is going to depend on two factors. The first factor is going to be the FVC, which is your forced vital capacity. And this is sort of known as the stroke volume of the lungs. And that is right here. Forced vital capacity. Inhaling all of the air, exhaling all of the air. All right, forced here. Forced vital capacity. The second factor is going to be breathing rate. So our speed of being able to move, volumes of air. So how we determine this is our forced expiratory volume, usually over 1 second, as well as our forced vital capacity, which is going to include our tidal volume, plus our IRV and our ERV. Tidal volume, plus our IRV and our ERV. That is our forced vital capacity. Again, make sure you kind of spend some time memorizing this, if nothing else, but obviously understanding what these terms mean. So the FEV to FVC ratio is going to be the percent of the lung size that can be exhaled in 1 second. So from pulmonary function tests, we can determine our forced expiratory volume. So an FEV over our FVC, we want to see that at 80%. So that means if you have an FEV over FVC ratio, a dynamic lung volume test of 80%, that means that you have a normal, healthy lung. So to put sort of a visual and a graph to this, here on the left, we have normal, where your FEV is right at 4 liters, and your FVC is at 5. So 4 divided by 5 is 80%. Now, if we have an unhealthy or obstructed lung, our FEV, look, is at, they're saying 1.2, and our FVC is at 3. So 1.2 divided by 3.0 is only a 40% capacity, which is indicative of something like COPD, or chronic obstructive pulmonary disease. So really, in simple terms, COPD means you just have a really hard time breathing. You certainly have some restrictions, maybe you have some fibrosis. And the way that we diagnose COPD, spirometry. Again, I really want you all to watch that 3-minute YouTube video. Also, from very fancy imaging that you would have done in a doctor's office, blood tests are also very accurate, and a pulse oximeter, put on your finger, will also give you some insights into COPD measurements. So this can be caused by smoking, the main factor. There's 2 main types: chronic bronchitis, which is going to be inflammation, or emphysema, which is going to be damage to air sacs, specifically the alveoli. And so this is what I did as an exercise physiologist in pulmonary rehab, was truly use exercise as a way to get these patients and individuals feeling better. Some of them had goals of running a 5K. Some of them had goals of just being able to walk around the grocery store for 20 minutes to buy food. So it really is sort of a debilitating and really, I guess, traumatic disease to have if you think about not being able to breathe or just getting up from a seated position and walking to the door, being out of breath. That definitely physiologically plays is a huge toll on your body, but also mentally. These patients are really affected as well. So the main goal for exercise therapy is to get patients moving again. So we know that stronger muscles make activities easier. And so I gave a little bit of insight into this, and I like to kind of tie in some of the things that we as exercise physiologists do with patients, if that's maybe a career that you hadn't thought about, or one that you've maybe heard us talk about here in kinesiology and health. So very rewarding to work with these patients. So when talking about lung function, aerobic fitness, physical performance, question, does regular endurance activity stimulate large increases in functional capacity of the pulmonary system? It does not. Lung tests can only predict lung disease. So if there is no disease, you cannot tell me from an elite Olympic marathoner. So your FVC cannot tell if you're an Olympic athlete, untrained, middle distance runner, wrestler, more anaerobically fit, more aerobically fit. However, I kind of said this, there's an exception to every rule. In what sport do athletes show development of larger than normal static lung volumes? Swimmers, for sure, and divers. So let's talk a little bit about running in the cold and what's happening on a physiological level. So again, remember that air is humidified as it passes down the trachea. So it is humidified, we said, in the conducting zone. And it does not matter what the temperature is outside. So by the time, I think Laramie would like to test this, but in general, by the time air reaches your lungs, it should be at about 98 to 100% humidity. So that burning lung sensation that we all feel here in Wyoming, that is caused by dehydration and irritation of the cells that line the trachea. So if you ever had sort of that post-exercise cough where it's just like dry and irritated, it's an unproductive cough, but it hurts. So that post-exercise cough is your respiratory tract losing water. So that's why even in the winter, when you're not sweating from that sun beating down on you and those hot, hot temperatures, you still need to stay hydrated because of just this, to decrease that burning sensation that you feel in the lungs. So here is a summary of pulmonary ventilation, kind of a knowledge check. So I encourage you to go through these questions. And if you have any questions, obviously reach out to me, and I will see you on the next one.